Good morning, everyone. Thank you for joining us. My name is Vanessa Moore. I'm the Scientific Project Manager for Dementia Research Network Ireland, DRNI. We're thrilled to hold this extended webinar this morning, Inclusion in Dementia Research. So over the next hour and a half, we will have 3 speakers followed by an expert discussion panel and a Q&A session. I want to start by welcoming our speakers and panelists, Professor Naaheed Mukadam from University College Dublin, Dr. Sarah Cullum, University of Auckland and the Global Brain Health Institute, GBHI, Dr. Georgia Richard, Trinity College Dublin, Cliona Ní Kelly, Trinity College Dublin, and Professor Sean Kennelly, Tala University Hospital. Thank you so much for everyone for being here today. Before I hand over to our first speaker, I just want to draw your attention to the Q&A box and the chat box that you should be able to see at the bottom of your screen. We'll have time at the end for questions, so feel free to put up your questions into the Q&A and to the chat box as they come up. It's no need to wait until the end, so just ask your questions as they come up at any stage. I'm going to double check now as well that the chat box is actually activated. Sometimes it's not. Right, so I will introduce our first speaker now, Naaheed Mukadam. You're very welcome here today, Naaheed. Thanks so much for agreeing to take part in the webinar. Naaheed Mukadam is a professor of psychiatry at University College London, where her research looks at inequalities in access to dementia services, including interventions to encourage earlier help seeking for dementia in South Asian people in the UK. She's also interested in the epidemiology of dementia, particularly environmental risk factors, dementia prevention, and how these may differ by ethnicity. Professor Mukadam is a member of the European Consortium on Cross-Cultural Neuropsychology, an international group that aims to improve the assessment of culturally and linguistically diverse individuals across Europe. Professor Mukadam was also an author on the 2024 Dementia Prevention, Intervention and Care 2004 report of the Lancet Standing Commission. In this talk, Professor Mukadam will provide details of underrepresentation of minoritized ethnic participants in dementia research and proposed inclusive research practices to overcome this. So over to you, Naaheed. Thank you.
Hi, thanks very much for having me. I'm Naaheed Mukadam. I'm a professor of psychiatry at UCL, and I'm just going to start sharing my screen so we can go through the slides. So I'll be talking about inclusion in dementia research as part of this meeting. Just some funding which led to completion of some of this work. So just to talk a bit about our society, I mean, I'm not so much aware about the situation in Ireland, but certainly within England and certainly within London, we have a very diverse population. I will be referring to people as minority ethnic groups. This is, I'm talking about people that are a statistical minority, although of course I acknowledge that many people who are called minorities in the UK are majorities in other parts of the world or globally. In the UK, generally, about 82% of people are self-define their ethnicity as white or white British, according to the last census, and there's about 18% that are minority group overall. And the main groups within the UK are South Asian, so these are people primarily from India, Pakistan, Bangladesh, Sri Lanka. And then the Black population with sort of diverse ancestral origins. So these are the risk factors for dementia. So I'll talk a little bit about the epidemiology of dementia and how our understanding of it is primarily based on looking at European origin populations. And then there's a bit on diagnosing dementia and other aspects of dementia, post-diagnostic support within diverse populations, as well as looking at inclusion in dementia research specifically and how we can improve on the current situation. So the list of environmental risk factors are taken from the Lancet Standing Commission. So this list is 14 risk factors that, based on our work on the Lancet Commission and essentially a sort of triangulation framework, applying causality principles, we have, and through consensus with experts, we've come up with these risk factors that have strong evidence that they may be causally linked to dementia. And then, of course, there are genetic risk factors, of which the one with the greatest impact is the ApoE4 allele. And then there are other genes with a smaller increase in risk. So people will often have polygenic risk scores to measure their overall genetic risk for dementia. Now, we know it's important to look at diverse populations for epidemiology as well, because we know for a start that within the UK, obesity, hypertension, and diabetes are more common in South Asian people than in the white population. So the risk of dementia based on population attributable fractions, which we calculated in the Lancet Commission, would be increased in this group. Hypertension is also increased in the Black population compared to the white population. And some of my work also found that the impact of some risk factors is greater in South Asian people compared to the white population, and the impact of hypertension was greater in the Black compared to the white population. So not only are some of these risk factors more common in some minority ethnic groups, but when they have the risk factor, the increase in dementia risk is greater than it would be if that same risk factor was in the white population. And of course, we know that ethnicity and deprivation are often correlated, and more deprived areas have higher air pollution and often a higher density of people from minority ethnic groups. So you can see that there's a greater vulnerability to dementia, not only because of these risk factors, but also in terms of the greater likelihood of being in a deprived area or coming from a socioeconomically deprived background. So we've talked a bit about risk factors. I'd also like to talk about the prevalence and incidence of dementia. So we're assuming that because people have more risk factors and the risk factors are more impactful, that this would give people from minority ethnic backgrounds an increased risk of dementia compared to the white population. So there have been some prevalence and incidence studies looking at this, some of which I've conducted. So we'll have a look at these now. This is the population attributable fraction from the Lancet Commission. So just showing the percentage of dementia cases that would be prevented if a risk factor was eliminated. So for example, you can see for less education, the number in the bubble is 5%. So if everyone was educated to sort of later in secondary school as opposed to finishing earlier, then we would estimate that up to 5% of dementia cases would be preventable. Of course, we know that we can't eliminate some of these risk factors, but the principle is the same. So the size of the circle, the size of the number indicates the relative impact of that risk factor. And we can see that overall up to 45% of dementia may be potentially preventable. But this varies depending on the context. So we did this work using the 1066 data, which had measured risk factors in different contexts. So in 6 Latin American countries, in India and in China. And we found sort of compared to, so this was based on the Lancet Commission from 2017. So at that time, the modifiable dementia cases was 35%. So you can see that compared to that, there's greater potential for dementia prevention in China, India, and Latin America. So this means that there's greater prevalence of risk factors, which means that there are some things that need to be tackled more in these contexts. So less education, for example, is particularly noticeable. In the previous diagram, the number was 5%, but in these areas where there may not be compulsory education up to a certain age, the percentage of cases attributable to less education is higher. And then when we think about, but the reason that we did that work was because in doing the first Lancet commission, we had noticed that most of the studies that we were finding, that we were getting prevalence figures from, and also the relative risks from, in order to calculate population attributable fractions, these were all mostly from European origin populations. So this was generally in white populations in the US, in a certain extent in the UK, and some from Australia and Canada. So it was hugely biased, and didn't really give a picture of, what actually was going on in other countries. So that's why we did the work in different countries, to show that the potential for dementia prevention and the importance of these risk factors, and the risk factors that are most important for dementia prevention, varies by country. And we found a similar thing with genetic risk factors, in that, so in general, when people do genetic analyses, they exclude anyone of non-European origin. And this is because patterns of linkage disequilibrium within the genome vary by ethnic group. And rather than trying to disentangle those effects, most researchers will just exclude anyone who's not of European origin from their analysis. So that means that many of the insights that we have around genetic risk factors are from European origin populations. And we can see from what's on the slide that the prevalence of different alleles varies in different populations. So in East Asia, for example, people with Alzheimer's dementia, only about 40% of them had the ApoE alleles, whereas in European populations, around 60% of them had the ApoE allele, E4 alleles. And there are some populations, for example, in India, that don't have the E4 allele at all, and yet I'm pretty sure that they get dementia. So, and there's lower frequency of the E4 alleles in many minority ethnic groups, compared to, particularly in the South Asian population, compared to the UK population, the white population. And there's been variations in the associations between ApoE and dementia in different parts of the world. So it's generally thought that in Africa, the ApoE E4 allele plays less of a role. So using UK Biobank data, I looked at genetic risk scores across different ethnic groups, as well as ApoE impact, and found that the impact of there was no different impact of ApoE, and also that the genetic risk scoring was similar and had a similar pattern to European GWAS. So the sort of implications are, I think, really we need to be doing more research using genetic testing as well from diverse populations. So, and now moving on to actual prevalence of dementia, around around 6.5–7% of people within Western Europe have dementia, and there's been a declining prevalence over the last 20 years. But if you look at minority ethnic groups, then, for example, Simon Edelman's study found a much higher rate of dementia in the African Caribbean population compared to the white population. And there are virtually no studies looking at South Asian. So there's no population-based studies looking at the South Asian population in terms of prevalence. The ones that have done surveys have found similar or higher prevalence. So it's really not clear what the situation is. So this is some work done by Tra Pham. So the panel on the left is from Simon Edelman's study, and then the one on the right is Tra Pham's study looking at primary care diagnosis. And you can see that sort of incidence of dementia is generally rising over the years, and the confidence intervals generally overlap, but it's sort of looks like it's higher generally in the Black population. So I used linked data. So TRAFAM study was just using primary care data. So I used linked data to get diagnoses from hospital episode statistics and mortality statistics, and found similarly a higher incidence and prevalence in the Black population. South Asian population was similar to the white population, and also there was not, for a couple of the years, it wasn't possible to even do prevalence because there were no data points for the South Asian population. So it's unclear whether it's just that this population isn't coming forward and therefore not getting picked up, or whether there truly is no increase in prevalence for the South Asian population. And just, to sort of say that similar patterns have been found in the US. So African American people have a higher incidence of dementia compared to the white population, but East Asian Americans have a lower incidence. So what happens after you get a diagnosis of dementia? So I found that there was a higher risk of death after dementia diagnosis in the Black and South Asian people. So there's shorter survival, about 3 years less after dementia diagnosis. It's unclear whether this is because people are getting diagnosed at a later stage. Certainly some of my earlier work seems to indicate that. And similarly in the US, survival after diagnosis, actually they sort of found the opposite, that white people had the shortest median survival, and this was longer in other ethnic groups. So basically we lack key data, really. We don't, there aren't good quality population-based surveys of minority ethnic groups. Simon Edelman's study was very good, but it's now 14 years ago. We need to be able to understand the epidemiology. We need improvements in diagnostic pathways, because we know that people from minority ethnic groups seek help later, often in the illness, often in response to a crisis, and this may be what's contributing to poor survival after diagnosis. And then also post-diagnostic support, there's issues around availability. For example, cognitive stimulation therapy can often only be offered in English. So how do you engage people for whom English is not their first language? And we're currently in the process of looking at national audit data to see whether there's differences in uptake as well in post-diagnostic support. So we started to think that actually there was a huge problem in terms of engaging people in research across the board, really, for epidemiological work, as well as health services related information. So we did some background reading and found that there is generally an underrepresentation of minority ethnic groups in dementia research. There's a systematic review of randomized control trials for dementia treatment, and very few of them even reported ethnicity. And in the ones that did report ethnicity, only 11% of people came from non-white backgrounds. And in UK trials, only one reported ethnicity, and very few were from minoritized ethnic backgrounds. So we just need to do a lot better in terms of including people in research, but also recording this. So making sure that there's, some sort of, as I say, so I think, that, so now, for example, the NIHR needs people submitting program grants to be thinking actively about inclusion, but I wonder if we can go further and and make it a requirement that people record ethnicity and report this in all of their publications. So how do we improve recruitment to trials? There's a scoping review by Bianca Bridgenath, so showing that language adaptations were the most reported approach, followed by engaging in community outreach and being flexible in terms of participation. And then Wahid et al. Also carried out this review. They identified 6 themes that hindered recruitment. Some of this is around community attitudes and belief. beliefs, the recruitment process. There's sort of also general mistrust around healthcare services, with good reason, because some of the practices in the past were unethical. And then thinking about practical issues and cultural adaptation, translation in terms of languages, and also researcher characteristics. So we need to be thinking maybe about the teams that are recruiting for these studies. So what we did was we aimed to gain a multi-perspective understanding of why there's an underrepresentation of minoritized ethnic populations in dementia research. And we did this by doing an online survey amongst healthcare professionals who diagnose and treat people with dementia, and also conducting focus groups with people from minority ethnic backgrounds. And the aim was to try and understand why this is happening and come up with strategies to overcome these. So we worked with community partners to design the study and ensure that we were taking diversity and inclusion into account. And they advised on recruitment materials, so posters and any sort of videos and so on that we posted to get engagement. And then we offered focus groups either online or in person, and had different times of the day, including evenings, so that we could accommodate caring responsibilities and people's schedules. So the online survey was in anyone who was doing research with human participants in aging or dementia-related research. And we sort of had a snowballing approach to recruit through email and professional networks. And then the focus groups was any adult from a Black or South Asian background. We narrowed it down to that because we wanted to capture the two largest ethnic minority groups in the UK and didn't want to have too much heterogeneity. Although, of course, there is huge variation even within those groups. They needed to be fluent in the English language, which I think is a potential limitation. And they needed to know someone with dementia or be living with dementia themselves. And we purposefully recruited to try and get people who hadn't previously participated in research. And then so we had a mix of focus groups and interviews. We applied thematic analysis and using the COMBI model. So this is capability, opportunity, and motivation, which is a behavior change framework that's quite helpful. The online survey had good participation across different ages and professions across all continents. And I think, people identified that they felt like they had a lack of skill amongst researchers, didn't know the populations well, there were language barriers, difficulties in recruiting, lack of finances to engage more. Obviously in grants there's often time pressure and financial pressure, so it was felt that that doesn't often equate to very good inclusive practices, and low diversity in the research groups. And then there was a feeling that minority groups didn't want to take part, and also took time to build trust and work with communities. So possible implications for practice are to, in recruitment campaigns, to use a trusted source, to be online and offline, because digital exclusion is, of course, a concern amongst many minority ethnic groups, but particularly from older populations and more deprived areas. Active community engagement and using culturally sensitive language. And then there should be funding for more inclusive research programs. So, think about diverse research groups, cultural competence training, and developing local relationships, including and then funder considerations, having ring-fenced funding, longer timelines, and maybe some sort of rules about recording and reporting ethnicity and inclusion data. So that's that, and I will stop talking now. Thank you.